Bismillahirrahmanirrahim. I welcome you all again to our EUS ERCP seminars that we have been conducting. I'm very pleased and honored that Professor Amjad Salamat, who needs no introduction in Pakistan when it comes to advanced endoscopy, has agreed to give us a talk on vascular anatomy today of EUS. So without any further delay, Amjad, over to you. आप screen share कर लें.
Thank you so much, Dr. Saad, for kind introduction. It's a pleasure talking to all of you. I think Wilson has done a great job educating for this education activities. So today I'll start off. The task given to me was basically the EUS linear anatomy of the mediastinum. Now, why I have modified a little bit that I've put in a vascular anatomy on the EUS, because basically vessels are the key on EUS to everything. So, of course, lesion recognition with a little bit of time, a little bit of experience. But once you want to orient yourself to the anatomy of the EUS, especially the linear anatomy, you cannot get away without knowing the vessels. So if you know the vessels, you're home, basically. So that's why I'm going to actually discuss the linear EUS and the mediastinum, but going on with the key, which is the vascular anatomy. Okay, so why is there a problem in linear EUS? You see, because it's a scanning, it's not a complete scanning. One actually looks at these different images and you have to see part of it. So, and you have to reconstruct a whole picture out of this sectoral scanning. So, so what is practical is basically when you're doing the EUS is that too much detail is not required. Major vascular identification is enough. And one should be cognizant of the fact that whatever you have learned about the anatomy, the previous learning, which you have your concepts of anatomy, which were taught to us in medical colleges, and after that, this interferes with actually the anatomy which we see on the US. So one should be, aware of these cognitive pitfalls while you're doing the EUS. That will actually, once you become an expert, then it doesn't really matter. But once you're trying to learn it and become an expert, or doing the clinical work, you need to be cognizant initially. So don't try to orient pictures according to what you think they should be. Rather, it is important that you actually look at the anatomy as it is. So what the brain keeps on trying to do is that whatever you have learned previously tries to superimpose this anatomical template from memory onto the incoming images. And the other thing, one should be cognizant of the fact that the images are basically, sometimes you see them in longitudinal sections, sometimes oblique, and sometimes in cross-section. And so that actually also creates a problem orienting to the anatomy. And of course, they're not colored images, they're grayscale, that's causes another problem.
So, excuse me, sir. Yeah. आप presentation share करेंगे या वो बाद में करेंगे क्योंकि अभी share नहीं है.
आ रही नहीं?
नहीं सर, आपने stop कर दी थी ना?
नहीं मैं तो नहीं किया. Okay.
Slide share दोबारा.
Your screen sharing. Your screen, it says that you're screen sharing.
No sir, okay. It's not showing.
पहले कर रही थी ना, ये पहले हो रहा था
जी, वो पहले कर ली थी, उसके बाद escape प्रेस किया था तो वो.
हाँ जी, अब देखिएगा दोबारा करके फिर करते हैं. स्टॉप शेयर कर रहा हूँ अभी मैं.
जी सर.
फिर मैं अभी शेयर कर रहा हूँ. अभी देखिए, अभी आ रही है?
यस सर, अब आ रही है. यस सर, यस सर. अब इसको फुल स्क्रीन कर दें सर.
Are you okay now?
Yes sir, it's okay now.
Okay. So this is what I was trying to say, and just what I said. And so, as I said, details are not required and all those things in cognitive interface. So we were here. So importance of study. So the vessels serve as landmark and guide to other structures and anatomies. And normal has to be recognized before you detect abnormality. So that's the importance. If you recognize the normal, then it's not difficult to recognize pathology. So the sources of confusion during your examination are because of the conventional teaching, and whatever is there is a variation in the anatomy, and these are the two major factors which cause problem. So the vessels are also important in staging of the disease, important in therapeutic procedures, and important in therapeutic targets. They can also be therapeutic targets themselves. So how can we study it effectively? In the case of mediastinum, it is a station approach, or you can actually trace the vessels region-wise. So we're going to discuss only the linear scope here because that's practical. Most of the units have the linear scope. Not many are using the radial scope. And so it depends really where you are taught, how you are taught, who is teaching you, what books you're looking at. And all of these approaches are okay as long as they work for you. So station region. So you can start with the neck and mediastinum, and you can divide them in upper, middle, and lower third, or upper, middle, and lower esophagus. And of course, for this presentation, probably we are going to ourselves to mediastinum. And the stomach, fundus, and body and antrum, you can divide them like that, or duodenal bulb, descending duodenum, or some people just number them, like station 1, 2 is in the duodenum, 3 is in the stomach, 3, 4, 5, 6, so like that. So it's really, as long as you know where you are and what things you're looking at, that's okay. So station approach has its advantages and disadvantages. I think for the people who are starting EUS and start learning, it's probably to master one station, then move on to the other. That helps. So the station approach probably is good if you're initially when you're learning, but those who have already learned them, probably they need to move on to a different approach. And most of us do that. Dr. Saad is doing that. Dr. Tayyib is doing that, and Yasnabi Tayyib is doing that, and because they have been doing all the time, so they everybody develops their own approach. But the point is not to miss the major landmarks and major pathology. So what are we looking at? So we're looking at arterial and venous things, and the aortic arch and its branches, great vessels in the heart, and celiac and SMA. I have included celiac and a little bit of SMA in the mediastinum because once you rotate the scope and you're trying to go into the abdomen, you see these basically in the thorax also. So aorta and its branches in the abdomen, but that's not we're going to discuss. And superior and inferior vena cava, mediastinum, this is we are going to discuss along with the once we see the heart. And of course, hepatic vein, portal vein, these are relevant, but they are usually included in the abdominal examination. Okay, so here's one thing which I want to share with you. So most of the time, what you will see in the images or in the books is that you have this image which is upright. I've intentionally put it on the side. The reason is that this is how the patient is lying down, actually. So if you look at that, and so that's how the patient is. The aortic arch goes like this. The spine is posterior, and the esophagus is like this, and goes there, and the fundus is like this. Now, this helps you to orient. So that's why I put it here. So if you put a scope here, actually, the esophagus is posterior. And if it is facing posteriorly, or if it is facing anteriorly, now you can see if you, what the images describe or what the movies describe or what the books describe. Now, if the scope is facing anteriorly and the patient is in the left lateral position, if you rotate the scope clockwise, the scope is going to look from this side, and it's going to move like this side, all right? And so actually you will see the subclavian first, and then you will see the common carotid, and then you will see the aortic arch. And if you keep on rotating, then you will see the azygos vein. So if you rotate it anti-clockwise, you're going to actually see posteriorly. So that will actually help you. And the heart, when you come here, the heart lies anterior. So when your heart lying anterior, and if you're moving the scope clockwise, it's actually moving to the right of the patient. And when you're moving it anti-clockwise, it's moving to the left of the patient. Now this will help you. I'll bring it all together and show you a movie also. So, but keep that in mind. So the anatomy actually is like this when the patient is lying in the left lateral position. All right, so we'll start with the images here. So look at this descending aorta. Now, this descending aorta and this left pulmonary artery here. So this will, as I said previously, cognitively you think, what the hell is happening here? I've been taught differently. This is my concept. Oh, how is it looking like this? So that's what we're going to do. So this is the arch of the aorta here, and it's a longitudinal. So the reason for that is longitudinal is that your scope, this linear scope is here, right above there, and it is looking at the aorta in a radial fashion like this. And so this bright shadow here is actually the pleura. So this is the aorta looking like this in the mediastinum. So this is the neck. So if you look at it, this is the left subclavian artery, and this is the left subclavian vein actually. And this is the aortic arch here. So the scope is actually being rotated anti-clockwise, and this is what you see. And this is anterior, but it is looking inferior. And this is because the patient is in the left lateral position. When the left lateral position, the left carotid is going to be here, the left brachiocephalic is going to be anterior to it, and the aortic arch is going to be like this. Now, if you rotate the scope clockwise, it's going to move from left to right of the patient. And then you will see, let's say, subclavian first, and then you see the common carotid first, and then you might, in certain cases, see they nominate. Okay. Now here's so this is the left common carotid, as you can see, and the scope has now been rotated clockwise further. So that is why you're able to see the left common carotid. And if you just do it anti-clockwise, the scope is going to move left inferiorly, and it was seeing the subclavian. So left brachiocephalic vein is again anterior to it, and this is lower border of the arch of the aorta, and this is the upper border of the arch of the aorta. And as you see, we are seeing upper and lower here, but it is on the image, it is probably looking upper and lower. So that's what I'm saying. You have to keep in mind how the anatomy is orients itself on the EUS. Okay, so sometimes this you don't have to remember this. This is not important also, but I just put it here as an example that sometimes you have to be familiar with other structures, because if you're not familiar, this can create confusion actually. For example, this bronchial artery is quite prominent here, and what has happened is here is that you have this going like this, and if somebody is not familiar with this, you can actually you can get confused what is happening here. Which artery is this? Where is it going? What's happening? So this is the arch of the aorta, and here's a lymph node here, and so this lymph node looks like this is in the AP window. This is the anterior posterior window. Okay. So we're all going to bring it together for you. So if you look at now, you have moved the scope, you have intubated the scope, and you've gone into the mediastinum, and this is the arch of the aorta. This is the subcarinal region here. This is the left pulmonary artery here. This is the aorta here, and there's a lymph node here anterior to the aorta. There's the left ventricle here, and this is it. Now this is the scope here. So the scope is lying posterior to the heart. It is looking anteriorly like this. And these are structures which you see in the subcarina, where you put your scope and you go below the division of the bronchi or main the trachea. All right. So if you rotate the scope a little bit, you would actually see the aortic root here and the aortic arch, which is, and you can see the valve here. So if you rotate it a little bit, you can, once you're doing the EUS scope, those who are doing, they would realize that if you do a minor clockwise and anti-clockwise rotation, you can actually see the aorta either in a longitudinal fashion or in a cross-section. When you see in the cross-section, you can see the Mercedes-Benz sign, you can see the origin of the coronary arteries, and if you see in the longitudinal, you can see the aortic outflow tract, plus you can see the valve, and you can see the aortic arch. I'll show you the images here. So this is the schematic representation here. You can see the aortic trunk here, and this is the right pulmonary artery here. Above that, you have this aortic root here, and this is the pulmonary trunk here. You can see this pulmonary trunk here. We'll look into that once we see the images. So this rotation, it really depends. If you're rotating it to the right, that is the clockwise rotation, you can actually see this pulmonary trunk. If you do an anti-clockwise, you'll see more of the left heart, aorta, and mitral valve, as well as left ventricle. So this is left atrium here. So the area between the pulmonary artery and the left atrium, this is the AP window. This is the subcranial region. So you can have lymph nodes here, tumors here, and you can biopsy them in this area. Okay, a bigger view. So this is the AP window. This is the arch of the. This is a little higher up. This is not the subcranial region. This is the arch of the aorta. This is the left subclavian artery. So this is just. Some people like to do it by going first into the subcrania and then pulling up, or some people like to just first explore the AP window and then go down. Either way, it's okay. You can do that. And once you look at that, so if you look at the thing, what you need to do is you should obtain a longitudinal view of the aorta once you have put in the scope, and then just pull it up and rotate it to have this view where you have arch of aorta around it, you have the left pulmonary artery around it here, and this is the AP window. Actually, the AP window is here, but by convention we call it here. So these are also called in mountain classification. This is station 6, and this is station 3A. So just anterior to the left subclavian, origin of the subclavian artery, and left common artery. So this is the station 3A, this is station 6, and you can biopsy that. You can biopsy from here also. So it's difficult to biopsy this one, but you can do that. So these things are important to know also, because you don't want to what you call a stage disease, especially if your pulmonologist and your oncologist is referring cases to you. Usually this has been taken by the under bronchial ultrasound, but nevertheless we see cases where we do all these things, take biopsies. The reason is that the endobronchial ultrasound is limited, and actually for accepting 2 stations, EUS can reach almost all the stations for the pulmonologist here. Okay, so this is again, if you orient yourself, I'm going to orient you here. This is the scope here. This is a sectoral scan here, and this has been rotated from, and this is the aortic arch. So once you're doing that, get an aortic arch, pull it back, and rotate it a little bit. You rotate, and as you rotate to the clockwise, you'll obtain a rounded view of pulmonary artery and arch of aorta, and in between them there's the AP window. Okay, and we're going to go back to the subcranial region here. This is the pulmonary artery, this is left atrium, and this is the subcranial region here. And you can see the aorta here and the aortic root here. And you can see this origin of the right coronary artery. Not important. We usually don't concentrate on that while we're doing that. The area of interest is usually here, or basically, yeah. So those people who are doing esophageal echocardiography, this might be more important for them. Similarly, you have this origin of the left coronary artery here, and you have the left atrium here, you have the pulmonary. Now this has been rotated clockwise, and you can see the aorta here is in almost cross section here, and you can see the valves here and the cusps, but the pulmonary trunk is now longitudinal, and you can see this right ventricle here and right ventricular outflow tract here. So this is just slight clockwise rotation, and you will get this image, but you have to do it slowly and deliberately. So this is now rotating to leftwards. So you can see this left atrium, and you have the mitral valve and the left ventricular here. And so basically, it's just a matter of rotation, the clockwise and anti-clockwise. But if you're familiar with these structures, you can make them out. So you don't have to remember the distances and all those things. Once you're familiar with anatomy, you just have to rotate the scope to know what is happening. Okay, so sorry. Yeah. So a little bit, because this is sometimes when you rotate the scope, actually in the thorax on the aorta, before just entering into the abdomen, you sometimes see this structure and you can get confused. And so this is occasionally you see this phrenic artery, just forget about that. What you see mainly is basically this splenic vein and the celiac artery, and then the celiac trunk, which actually gives the left gastric, which goes up, and then you have this goes forward and divides that. So this is just before. So sometimes you can see it in the thorax, and then you see the across the diaphragm. Just to put it there, to for your information, that if you see that in the mediastinum, that's going to be. Don't get confused. So now I'm going to bring it all together. This might be actually because I showed you the pictures, they were disjointed. But we're going to look at the actual performance of the echocardiography, this endosonography in the mediastinum, and then you can understand while we're playing it many of these things. So if you have any questions, then we can just keep on posting them. We can discuss it after this. Okay, so I'm going to do this, and then let's see how it goes.
Mediastinum can be examined from 4 different positions. Pushing in or pulling out changes the position. At each position, a home base is identified, and the scope is rotated by 180 degrees to 360 degrees. In this figure, the respiratory tract is shown in white with stripes. Other structures shown are, in blue, superior vena cava with azygos vein, in pink, ascending aorta, aortic arch, and descending aorta, in deep blue, main pulmonary and its branches, and in light orange, left atrium and the pulmonary veins.
The left atrium pulmonary. So this is showing the sectoral scanning of the figure.
The upper border of the arch of aorta forms the lower limit of imaging from the first position. This video shows the origin great vessels of neck above the level of the arch of aorta. The left subclavian artery is seen taking origin from the top of the arch. Further clockwise rotation can show the origin of the left common carotid artery. It is more difficult to follow the course of the brachiocephalic trunk as it crosses to the right side in front of the trachea. But in thin patients like this, the brachiocephalic trunk can be seen. Throughout this video, the left brachiocephalic vein is seen lying anterior to the great vessels of neck, taking origin from the arch of aorta.
So this is the venous trunk, basically. Brachiocephalic trunk. This is left brachiocephalic vein when it joins.
This animation shows structures above the level of the arch of aorta. With a clockwise rotation from the left wall of the esophagus, the origin of left subclavian artery, the left common carotid artery, and occasionally the brachiocephalic trunk may be seen.
So now you can understand, because the esophagus is posterior.
The union of the left subclavian vein with the left internal jugular vein to form the left brachiocephalic vein is seen. The caliber of the left internal jugular vein becomes larger when it is followed up from an intrathoracic part to extrathoracic part. A lymph node lies in front of the left common carotid artery and the left internal jugular vein and belongs to station 3A.
So this is the one I showed you in the figures.
Initially, the descending aorta is identified at around 30 centimeters, and a clockwise rotation is started after application of color Doppler box adjacent to the esophagus. The azygous vein appears as a thin longitudinal echo-pore structure adjacent to the middle part of the esophageal wall. The shadow of the spine and the intervertebral disc can be seen in this video, along with the azygous vein. Clockwise rotation shows the posterior intercostal arteries taking origin from the aorta and going behind the azygous vein. The presence of indentation due to posterior intercostal arteries along the posterior border of the azygous vein and presence of numerous intercostal veins joining the lateral border of azygous vein helps in additional characterization of the azygous vein.
This is, you can actually rotate it anti-clockwise to the right, or you can rotate it 360 degrees to the opposite side, you'll have the same result. So whichever is comfortable for you and the scope. So mind you, if you're doing that, it's probably good to move away from the patient a little bit so that your scope is straighter and you have a more response from the tip.
The descending aorta is located in a location posterior to the esophagus. When the scope is pulled back slowly, the descending aorta is traced up as a large tubular structure which forms a bright, deep interface with the left lung.
So this is the
interface with the left lung sometimes creates a mirror image of the descending aorta. The origin of the left subclavian artery from the upper border of arch is also seen.
Oh, sorry. Start from there.
Clockwise rotation in presence of numerous intercostal veins. To the esophagus. When the scope is pulled back slowly, the descending aorta is traced up as a large tubular structure which forms a bright, deep interface with the left lung. The interface with the left lung sometimes creates a mirror image of the descending aorta. The origin of the left subclavian artery from the upper border of arch is also seen.
This is.
About 25 centimeters from the incisor, the azygous vein arch and the aortic arch are seen. The aortic arch can be traced into the descending aorta. The azygous vein arch goes away from the probe, but the join into the superior vena cava is difficult to see.
So azygous arch is not seen, but azygous vein can be seen easily. And as you can see, if you rotate it, basically clockwise.
Area below the arch consists of the aorta pulmonary window and the subcarinal space. Clockwise rotation shows the course of the right pulmonary artery as it goes into the right lung and divides into two branches. The main pulmonary artery is rarely visible because of its depth and its position in front of the trachea and main stem bronchi. The subcarinal area is a pyramidal space, the tip of which lies at the tracheal bifurcation. The right boundary is formed by the right and intermediate bronchus.
The right bronchus.
The left boundary is formed by the left main bronchus. The lower boundary is formed by the left atrium. The AP window is a middle mediastinal space which lies immediately below the arch of aorta above the left pulmonary artery.
So AP window is here.
This video shows the mediastinal structures at the level of the left atrium. Once the left atrium is visualized, generally clockwise rotation with slight manipulation shows the right-sided outflow tract, and slight anti-clockwise rotation shows the left ventricular outflow tract. If clockwise rotation is done slowly along the left atrium, it brings the mitral valve into view. Beyond the mitral valve, the left ventricle is seen. The left ventricle can be followed up to the aortic root, slightly proximal to the mitral valve. From the left atrium, the left ventricular outflow tract, and from the pulmonary artery, the left ventricular outflow tract can be followed. The superior vena cava and inferior vena cava can be seen joining in the right atrium, from where they flow into the right ventricle through the tricuspid valve. The pulmonary trunk can be seen taking origin from the right ventricle.
That's the right superior vena cava here. This is right atrium, this is inferior vena cava. This is the SVC. That's the SVC. That's the left atrium there. This is the pleura here.
The mediastinal structures during rotation at 33 centimeters show left atrium as a large pulsatile chamber at the lower limit of the subcarinal area. With a clockwise rotation and withdrawal, the aortic outflow tract, aortic valve, and ascending aorta can be visualized through the left atrium. The mitral valve is seen between the left atrium and left ventricle.
This is the left ventricle, this is the left ventricular outflow tract, this is the aorta here. That's the left atrium, this is the mitral valve here. Okay, I think that's what the video shows. So this is the pulmonary trunk. If you rotate it anti-clockwise towards your right shoulder, this will go towards the right shoulder of the patient. So this will help you. This is the right ventricular outflow tract, and you can see this going there. Okay, so from the practical point of view, what is most important is that you should be familiar with the subcarinal area and the AP window, because most of the time we have the lymph nodes there. And these lymph nodes need to be biopsied, and you can do that basically easily, because the scope is usually straight in the esophagus. There is no problem putting in the needle. You don't have to exert much. The needle is straight, and the only thing is that you should be familiar with the structures and just make sure that you're not puncturing a great vessel or the heart. One should know that. I think this video doesn't tell us, but you can look into the lymph nodes, because the lymph nodes are usually in subcarinal region, and also at near the GE junction. They are just above the liver, and which is the station 9, just above the diaphragm, and in the and near the azygous vein. So those lymph nodes are sometimes sampled, and they're important. The other day we had a lymph node. There was a question in a case, and he had multiple lymph nodes, and one of those lymph nodes was actually situated in the near the azygous vein. We sampled that. Luckily, it was negative. So sometimes, in certain conditions, when your referring clinician wants certain particular situation, they might like to want biopsies in those areas. It's not difficult. What you do is you just, as it has explained, this video has explained in the initial part, that you can rotate the scope. So you can, once you have your hair, you can actually rotate the scope, keep on rotating clockwise, you will reach the azygous vein there, and you can have the lymph node nearby. So I'll stop here. If you have any questions, I think that will be more probably helpful to basically clarify your doubts about the mediastinum.
Amjad. Thank you, Amjad. You've still got talk to continue, right? Or are you done?
I'm okay. I'm done. I would probably like to interact so that I think we can discuss those doubts.
So a couple of questions that I would start with while we are waiting for people to ask questions. Thank you very much for the talk. Amjad, when you're looking at the upper mediastinum, are you doing your EUSs with propofol or general anesthesia or MAC, or are you doing them under sedation? Are you using sedation or are you using?
We're using nowadays. We're using MAC basically because we have an anesthetic.
The reason why I asked is one of the things that I've noticed is that when you're looking at the upper, when you're examining the upper mediastinum, especially the AP window and above, the patient becomes very uncomfortable because there's pressure and they start becoming uncomfortable. So I think if you want to really examine the upper mediastinum, especially properly, then you need to have the patient under MAC, or would you agree with that?
That is true. One of the reasons is that once you actually, once you're in the AP window, just above the what you call as subclavian region, you have to just, when you're pulling the scope, you have to just turn the tip upwards, and that actually irritates the trachea. And these patients actually start coughing and they become uncomfortable. So I think the MAC helps there, really.
Yeah. The second thing is that in your experience, how often have you used or you find utility of the vasculature of the upper mediastinum vis-a-vis GI related issues? Have you because I know you have an interest as well as experience as well.
Yeah, I think as I said, basically the vascular structures are not important from the GI point of view, but they are important from the anatomical point of view, where you are and where you are. So these big vessels will actually tell you where you are. For example, even if you're new, you don't have to look at the azygos and all those things because they're not important. What is important is that if you recognize clearly that this is the left atrium, this is the pulmonary artery, and this is where the lymph node is, that's good enough. And if you recognize the AP window, that's good enough. And so that is good enough. But I think sometimes what happens is that you have these tumors which are in the posterior mediastinum. You might have encountered those. We encountered them, for example, neurofibroma, sometimes other cystic tumors, and bronchogenic cysts and all those things. So basically what I'm getting at is that if you know the normal anatomy, what actually lies in the mediastinum, you're able to not make a mistake and recognize the pathology. But as I said, you don't have to go into a lot of detail. That's not required actually from the GA point of view.
Lastly, before I ask Khalid and Nadeem, I know they are online and I would like them to come into the discussion. The last thing is that, the lymph nodes that you see in the mediastinum, with the prevalence of tuberculosis that we have, and how in your practice you decide when you would worry about a lymph node for doing a biopsy or just leave them?
I think if you have a large lymph node which is more than 1 centimeter in the shortest diameter, it is rounded, it is hypoechoic, and you look at it, so that's usually abnormal. But then it's accurate in 80% of the cases. In 20% of the cases, you still have to do a biopsy. So that's why we sample all of them, especially if you're looking at the lymph node which is rounded, hypoechoic, abnormal, so discrete, right? But if you have an elliptical lymph node with a hyperechoic medulla and shortest diameter is it's less than 1 centimeter, so we're not worried. And but again, having said that, but if you have a surrounding structure that you have a tumor around that and all those things, and you think that this is really near that and it is important to sample the lymph node, you can. But in that particular case, you already have the tumor there. So yeah, so endoscopically, if you're looking at just on the appearance, you'll be probably 75 to 80% of the time right. But that's why you have to do the biopsy. So those lymph nodes which are less than 1 centimeter and all those things, you think they are reactive, they're elliptical or triangular, and they're not, the characteristics are not matching what is the teaching, probably you can leave them alone if you don't have any other pathology also. Okay,
thank you so much. Khalid, you're there. If you are, or Nadeem, can I ask you to come in and add or discuss?
Assalamu alaikum, welcome.
Nadeem, want to go first or should I go first?
Yeah, you go first.
You go ahead.
You America first.
Okay. Assalamu alaikum, Amjad bhai. Thank you so much. I'm always intrigued when you explain the vascular anatomy in the mediastinum. So I'll just summarize Amjad bhai's talk in 30 seconds and or maybe 1 minute. For those who are starting or those who are still kind of at an intermediate level for EUS for mediastinum, just remember that when a patient is laying on left lateral and obviously esophagus is just posterior mediastinum, that's where it's going through. When you put the scope into the patient, your what I call a neutral position of the scope. When the scope is your head, like a controller is resting on your palm, views facing up. So that's the most neutral, that's the neutral position of the scope. So in that position, the transducer is looking anteriorly towards the everything which is in the mediastinum. So from there, when you are in that position, if you rotate the scope clockwise, you're rotating to the right, that would look at anything which is in the right mediastinum or the right side of the patient. But
wait,
that,
2 minutes.
That would be...
When you go from the other side.
I just put my back in the bench.
His kids want to participate.
We have your mic.
Nadeem, can you mute your mic?
Nadeem, can you mute your mic, please?
Muted, sir. Muted.
Thank you.
So when you're rotating the scope to the right, that is like clockwise, that is looking at the right side, all the structures in the right mediastinum or whatever you can see, everything which is in the right, that's going to be seen by that. But that on the screen, when you're looking at the screen, that's the left side of the screen. Okay, so if you wanted like rotating to the right, clockwise, looking at the right structure, the right side of the patient's body, but your screen, which you monitor, you are looking at, that's the left side of the monitor. So same thing is the other way. When you rotate anti-clockwise, downwards, then that's looking at patient's left side, but your screen is going to be right side. So these are the things with regard to anatomy and your orientation of scope. From practical point of view, for me, only 2 stations really as a GI person or a GI endosonographer, only mainly 2 things which matter to me. One is the subcrina, other is the AP window. Subcrina, when you see the lymph nodes in there, actually you should be able to find the lymph node in subcrina in pretty much every single person. So finding a lymph node in subcrina is not a pathology. Most of the times you see those. It usually is like if they are very enlarged, they are conglomerated lymph nodes, they are what their structure looks like, what their echogenicity is, that guides you if it's a pathological or it's a physiological lymph node. But when you see the AP window lymph nodes, and that may be pointing towards the abnormality. And Amjad Bhai very rightfully earlier said the AP window really, which we call a AP window on EUS examination, is really not the AP window. It's a little bit above that, what we are looking at. But when you see the lymph nodes in that are really pointing towards some sort of pathology. Maybe it could be a cancer, could be a tuberculosis, or whatever you want to, whatever the pathology is. When you see those, that may be a problematic. And these are the only really two places. There is the third two, but these are the only two places where you can easily approach these lymph nodes if you have to biopsy. Other thing what you can do is, which I have done all the time, is these lung masses which are really close to the esophagus. They are very easy to do FNA through the esophagus or biopsy those. I just did one yesterday, and they are easily, you can see those. When you do, even though they are lung-based, but when they are attached or very close to the esophagus, you really don't run into any sort of trouble there. And by the way, just I always talk about historical perspective of all these. So first FNA, which was performed by EUS, was a mediastinal FNA by Dr. Peter Willman. He performed the first FNA, and that was really from the mediastinal lymph node. And the mediastinum is the easiest place to do FNA, because your scope is really, really straight, and you can easily avoid vasculature and everything. So other thing, all these, you can, I already explained that. You can, for me, from practical point of view, mediastinum is the last thing which I look at during my EUS examination. Coming from down up is easier to find these landmarks than as compared to going from as soon as you enter the esophagus and going downwards. So make a habit whenever you do a EUS, mediastinum, do the mediastinum at the end, but do it really step by step. And first thing you are going to look for is the subcrania, then AP window, and then keep coming up. You can find the if you are interested in aorta, or aortic arch, and then you can look at those as well. But practical point of view, these are the only two things. Other thing which you can really see well is thyroid gland, and that is best seen on your entry into the esophagus. And if you're interested in looking at that, always you will see that best there. So that's, I think I'll stop there. If there are any questions, I'll be happy to, but Amjad Bhai very elaborately explained all the anatomy, and every time I listen to his talk on vasculature, I get intrigued about that. And he, I think, knows more about the vessels than anybody else.
Khalid Bhai, I'll completely second everything that you've just said. And I think absolutely spot on with regards to Professor Amjad Salamat's skills level, and especially when it comes down to the vascular anatomy. I'm just going to add a couple of things from what you've already said. I think it's, as you've said, it's definitely the easiest area to do the mediastinal sort of lymph node biopsies. But I would also like to add, is probably one of those areas which also has a highest risk of causing complications, especially if your patient is not really nicely sedated. And I mean, we prefer patient really intubated. The other thing, as you've said, we've recently encountered a case of esophageal mesothelioma where a patient didn't have any exposure, and sampling was probably the easiest thing. There was a patient, unfortunately, about 2 years ago, where there was a complication following a mediastinal lymph node biopsies, where we ended up causing trauma to the esophageal wall, and patient ended up having significant mediastinitis and required prolonged hospital stay. So those things, I think, needs to be borne in mind. And one more thing, I think if you make a habit of sort of reviewing the anatomy, then one of the common, so anatomical variation that we see, especially when it comes down to the HPV malignancy, for example, the right replaced hepatic artery. So the anatomical variation is something that you mostly see in vascular anatomy. And therefore, again, that is, if one is accustomed to sort of seeing the normal anatomy, then when you spot anatomical variation, one will be able to appreciate it better. But great talk, and thank you very much for sharing your expertise.
So on that perspective, Saad bhai and Amjad bhai, what is have you encountered complications with the esophageal, this mediastinal EUS?
I personally haven't. I think maybe not doing much because since the endobronchial ultrasound, I think our cases have dwindled because we used to get many more. In the initial stages when this was not there, we published a review of 80, 90 cases, and we used to get more. But I remember one of my trainee was doing it when he didn't realize that there were varices, esophageal varices. So but then even that was not a problem because we went in and just banded them. He had just accidentally put a needle in that. So I think by and large, I think it's quite safe. And I think the only thing which I think is what happens is that if you're not careful, if you're doing the AP window and the patient sort of coughs suddenly, if he's not sedated properly, you might sort of win. One strange thing which had happened actually to me was, I can't explain it till today, is that I went in and I actually biopsied a lymph node, and I was doing there, and the needle got stuck there. It was very strange because each time when you started to pull it, actually the esophagus would come up, and the patient would have pain. So we were quite intrigued, and we just cut the needle and send him that, because each time then we didn't want to rupture the esophagus. But once he reached there, the guys actually put him there. They say, okay, we'll see if we can go in, all those things. And while they were preparing him for surgery or something, he coughed out the needle. We looked at the needle, we looked at everything, and really I can't explain it to this day. What happened? Where did it stuck? The needle was not bent. The needle was okay. It was moving in the sheath. The guy was okay. That's the only thing I think happened in the midtime to me.
Yeah, I think in my experience, complications can happen anywhere. Doesn't matter where you are. And but overall, I think it's quite safe. Just whenever you do a FNAs, because one thing is, to Nadim's point, it's like a tubular structure. So what you have to do is like, you can't do a FNA from at an angle of when your trajectory is close to 180. You have to bring it to close to 90 degrees to the wall. So if you're not careful in that, maybe you can run into a problem. But overall, in my experience, I think it's quite safe. And just whenever you do that FNA, for that matter, anywhere, whichever lesion you are going to do a FNA or biopsy, you always have to bring that as close as possible to the transducer. So if you care, doesn't matter where that is, when you keep that principle in your mind, and without having to bend the needle or without having to use the elevator, I think it's overall quite safe.
Okay, I totally agree with Khalid and Amjad Sahab. I think we've not encountered anything so far, luckily, alhamdulillah, over the last whatever years we've been doing FNAs in mediastinum. Fortunately, we've been lucky elsewhere as well. But like you said, complication is part of doing procedures, and one has to be careful. I mean, one has to understand where the lymph node is, bring it exactly where, like you said, align it properly, and know how far you need to go. And if it's very hard, then there is no harm in restricting your needle so that you know how far you're going to puncture. If you're doing it early, that sometimes helps, where you can lock your needle and make sure it doesn't go beyond a certain point. But by and large, I think it's not difficult at all, because the lymph nodes are right next to you. It's straight tube. It's not generally angled so much. So I think this is, like you said, it's probably the best to learn. And in terms of safety, I think it's also safe to start with. This is what
I think Khalid's unit always, I think, because Rob Hawes is there, so he's always said that one should look into the advanced station, master that, and then move on to the next, and I think I don't know if he still propagates that approach because I think he's the one who said that. And there are others also who say that if you look at the station, because I think in the learning phase, probably the station approach saves you time instead of you getting lost.
I think the mention when you mentioned that the stationed approach is not only changed also, because in the initial you had more stations, and now that you can actually literally divide them into practically duodenum, stomach, and mediastinum or esophagus. So if you can use whatever, but like you said in your talk, I think it's when you start doing them, you make your own systems and practices. But one thing Rob Haas mentioned in that video, and I think that's a wonderful video by Olympus. It's one of the best there is by Rob. But there he mentions one thing, and I think that's something that I find very useful, is that if you lose your area and you're not sure at whichever station you are, you go back, restart. Don't waste time without understanding the anatomy or understanding at least some organ, because then what happens is you keep on messing it up, especially in the early days. Otherwise, once you get into it, I think EUS is relatively straightforward in terms of what you can see and how you can get those views that you need to see.
That's true. I've seen Dr. Khalid doing that, so it's so smooth. I mean, he goes to the second part. You don't even realize that once he's at the tail of the pancreas that he's come out.
We have a question.
Question from on the pancreas all the time. So that's actually very very nice too, because once does that. So that just tells you that it's we tend to divide that into different parts, but it's all a smooth. It should be a smooth operation.
They are connected, but yet they can be viewed from different areas. There's a question here: is it risky if we puncture accidentally a vascular structure?
So, Amjad, you want to answer that?
Yeah, I'll give my opinion, but I would like your opinion also. Okay. I think what I've seen is that even if you do that, basically, if you have a 25 gauge needle, or even sometimes we have seen with a 19 gauge needle, it's usually not a problem. But and I think it's one need to avoid that. It's not to say that you should be doing that, but I'm really, really careful usually when it's a vein. You don't want to, and especially if it is extrahepatic or something like that, and it's near the tumor, you don't want to do it the vein, because the thing is that, and if the patient doesn't have the coagulopathy, usually there's not a problem. But the whole thing is that if something happens, then you're not able to do something about it. So that's the main issue. Arteries usually close up. I think it's the vein. I find the veins we should be more careful.
Yeah. So there's the physiological explanation behind that. When you hit the artery, it's a strong circular muscle. And also when you hit the artery, it spasms. So arterial puncture is friendly to you. Venous puncture is not, as Amjad rightfully said. So if you puncture a vessel, majority of the time, be it even if it's a vein or artery, you're gonna be fine. Just don't keep doing over and over. Just stop. Just don't test your luck. So once to give you an example, my teacher, Dr. Wallace, taught me EUS, Mike Wallace. I did not learn EUS, by the way, from Dr. Haas. I did.
I know that. What I'm saying is that he was in unit.
Yeah, no. What I meant indirectly from him, because Mike Wallace is his student. So I was just Mike Wallace. One time this was a very difficult case. They needed a FNA of a lymph node which was across the aorta. So they have to go through aorta with the needle, through and through, to get a FNA. And so that point is like, yeah, majority of the time you're going to be fine. Just don't keep doing it. Don't panic. Pull the needle out. If it's a FNA needle, usually no problem at all. It's the only time which the problem happens is when you hit the vessel in a longitudinal wall area. So you kind of rupture through that. When you go through the vessel at a 90 angle or anything, no problem. It's just when you rupture the wall alongside it of the vessel, that's where the problem is. So if you think there's a lot of vasculature, but you have to do a FNA, don't use a core needle. Use a FNA needle. Don't use FNB needle in that case. So you'll be fine. And majority of the time it's not a problem. So
does it matter? Does it matter with the size of the needles? I mean, like 19, 22, or 25. What you've ruptured your vessel with?
Yeah, smaller the gauge, safer it is. Definitely, no question about that. And
I'm sure you would agree that quite often we've actually gone through smaller vessels. We don't sometimes even probably
realize that we did it.
Yeah.
And to be honest with you, I sometimes turn the Doppler off. I don't want to see it.
I do that because that's that also
that makes you more scared than you really are.
Just a word of caution here. Sometimes you mistake an aneurysm, so don't do that to an aneurysm. Don't put a needle in an aneurysm, because one of the days one of my colleagues was doing that, and he said that I just want to biopsy this. So I just told him that kindly
biopsy a vascular structure. Colleague needs to be careful.
And it's on the same lines. I have biopsied a tumor from the portal vein too. So because that's the only thing, even though like they have to differentiate it, is really a thrombus or a tumor thrombus.
But then you've got a thrombus there, right?
No. There are two. Like if there is a tumor there, is it a tumor penetration?
No. What I mean is that you have a structure within that portal vein, so that also helps.
Oh, absolutely. Yeah, and you see it's a structure in there. So they had to differentiate if it's really a vascular thrombus or a tumor thrombus.
While we are at it, and I don't know if we have time. Well, we are actually gone past the time. So unless there is something, anything that you want to add, Amjad?
I think that what I would suggest is that while you're doing that, but just be careful. Just word about if we are using the older scopes like the Pentax scopes and all those things, and if you're not putting a balloon on them, just be careful when you're going through the throat. You can actually cause a problem there, and when you're going to the duodenum. So I think just be very, very careful when you're putting this long nose scope from throat. I think Olympus scopes is very good now. It's rounded tip and not a problem. Just a word of caution. Just don't push.
No, I think that's a very valid point, especially when you were drawing the scope and if your elevator has to be sort of in a neutral position, because that could also cause a trauma. And I think lastly, just one quick thing, as Khalid Bhai had said, I think during previous sessions with the hepatic vessels, especially with that smooth muscle wall, you get this bouncing off phenomenon, which also kind of alerts you that you're going in the wrong territory. But no, otherwise, absolutely fantastic.
I think I couldn't agree with you more. I think you have to be very careful when you're intubating, even when you're using Olympus scopes, especially when you're in the early stages. We in our courses tell people that please don't use the word push. We advance the scope, which means if you have resistance, you do not. Pushing is advancing the scope against resistance, which should not be done in any endoscopic procedure, but especially with the hard tipped and thick EUS scope, it obviously increases. With that, I think we've passed the time. I would like to thank Professor Amjad Salamat for an elaborate and detailed talk and a very interesting coverage of the topic. Thank you, Khalid and Nadeem, for your inputs. I thank all the participants for being part of this. Riaz unfortunately had a commitment today, something that he could not avoid, so I had to take over his task. I would like to thank Wilson's for their support, for all the EUS, ERCP, and gastroenterology activity relating to teaching. Thank you very much, everybody, and hope to see you Wednesday. And Wednesday we have a very interesting talk on nutrition, which is going to be from. Sorry, I beg your pardon. Tuesday. I beg your pardon. Tuesday at 10:30 Pakistan time. We have somebody from Southampton, which is one of the centers, one of the best centers in UK as far as nutrition is concerned. I'm sure other things as well. But so I would request and urge all those, especially those who are relatively younger, junior, and undergoing training, to attend the session. It will be lovely on TPN to hopefully cover this. And then after that, we have another talk on intestinal failure, and those two should cover the nutritional side of hopefully of our PSP training as well. So thank you very much, and I look forward to seeing you inshallah on Tuesday.
Nice seeing Dr. Khalid and Dr. Hani. Okay.
Okay. Okay.
Thank you, sir. Thank you.